Going to do some practice problems. Okay, so we're going to go back to our original problem. AM is a 40-year-old, 5'9", 78 kilogram man suffering from epilepsy. He needs to be started on an oral phenytoin regimen. Please determine a starting dose for sodium phenytoin. 100 milligram and 30 milligram caps are available. So instead of trying to hand calculate, we're going to use some of the tools we have available. So here's where we're going to go and click on this link that's in global RPH, which I guess I can't do here. All right, let me just stop sharing this and we'll share something else. How about that? I'm going to go to that link. So, am I sharing the right screen now? We're going to go to that. Yes, this is the link we want. So we're in global RPH now, which is one of the dosing tools we have available to us. And this is the phenytoin dosing calculator. So there's a lot of cautions on here and you should read all that. And here we'll put in the patient's name and floor number, which I don't know. But let's see, the age is 40 years old. I think it's patient AM. Weight is in kilograms and it's 78 kilograms. And it's a male that's 5'9". So we're not in centimeters, we're gonna be in inches. 5 feet is 60 inches, and 9 inches it is 69 inches. A male, his current albumin level is normal as far as we know. We don't have that information. But if we did, we would put it in, and that's something certainly we need to know. And as far as we know, he doesn't have any phenytoin in his system right now. So his phenytoin level is 0. And we're not giving IV or capsules. We're going to give tablets. And as far as we know, his renal function is good, which is also important because of binding. So then we just hit calculate. And results. Okay, it tells you the ideal body weight, the dosing weight, and recommended loading dose for a patient not currently receiving phenytoin. If you wanted to shoot for 10 milligrams per kilogram, it's going to be 736. So you can pick any of these levels. I think we came up with between 700 and 750, didn't we? So I think we were shooting for a 700 range. And the maintenance dose, we came up with 400, and it looks like we were right on the button with that. So using this range, I would probably pick 400 a day, normally given in doses Q8 to Q12. Obviously, if he had renal insufficiency or hypoalbuminemia, we would think differently about this. All right, so that's pretty groovy, right? We can just put that in there. And I'm going to give you another example of that in your workshop. Sorry, you get to see all the clothes I like to buy. So let's see. There are a lot of ads with global RPH, or at least I don't pay for it. So, all right, so let me stop sharing this. Go back to our problem there. So we're going to go with probably 700 or 800 milligram load and 400 milligrams a day, probably 200 Q12 using global RPH. Now, here's another case. JP is epilepsy treated with 400 milligrams phenytoin daily. He's in an auto accident and is admitted to the ICU and goes into renal failure. So that's important to know because then we have problems with our binding. His creatinine clearance is estimated to be 15 mils per minute, which is very low. It would be considered renal failure, and his albumin drops to 2 grams per deciliter. His phenytoin concentration is at 6.5, and the team wants to increase the phenytoin dose because remember, the therapeutic range is 10 to 20, But we also know if the binding changes, we can't trust the total concentration. So how are we going to adjust this concentrations that we're reading to reflect what's really happening as far as adjusting the phenytoin concentration to reflect what's happening with um, the actual phenytoin. All right, well, we are going to, again, well, here's our equations. So patients without end-stage renal failure, this is one equation you can use, to another equation you can use. So you put in your measured phenytoin here, multiply 0.25 times your albumin level in grams per deciliter, and then add a 0.01. Or you can use 0.29. And then if you have end-stage renal failure, that makes it even more of a problem. So now your fudge factor goes to 0.2. So your corrected phenytoin is the phenytoin concentration that would have been observed if the patient's serum albumin was normal. So normal is 3.5 to 5.4. So if we go back, let's just quickly remember here. So he's got 15 mils per minute. So he's got renal failure. Albumin is 2, which is normal is 3.5 to 5.4. And his phenytoin concentration is read as 6.5, which seems pretty low. So now we're going to use our clinical calc tool. All right, I'm going to switch my, oops, that's not what I want. I want this. So we're now going to our phenytoin correction calculator, and this is on a second um, tool called ClinCalc. So in this phenytoin correction calculator, you're going to put in your patient's albumin, which was 2, and their phenytoin concentration, which was 6.5. And are they on dialysis or end-stage renal failure? Yes, they're in end-stage renal failure. Are they getting concurrent valproic acid? Not that we know of. So I'm going to say no to that. And notice all the equations that they're using are all in here. And you should read all that. I don't have time to go over it today, but so the calculated corrected total phenytoin level is 13 milligrams per liter. So they're well within the therapeutic range. So I would leave it alone. So you can see it's double what the total concentration measures with this type of renal failure and hypoalbuminemia. So isn't this fun that we can do this without doing all that calculating? Yay! All right, so let's, I think I have one more case here for you. Um, so we're gonna leave them leave them on the regimen that they're on. Case number 3, TF is a 25-year-old woman on both valproic acid, 250 milligrams TID, and phenytoin, 300 milligrams daily. She reports some double vision and dizziness. So we're worried about both of these drugs with that, but we do know that valproic acid displaces phenytoin from its binding site. So the valproic acid concentration is 80, which is in the therapeutic range, and the phenytoin concentration is 15, which is in the therapeutic range. But again, if valproic acid is displacing the phenytoin from its protein binding sites, and I think it induces the enzymes that cleared phenytoin, we could be seeing this is not truly what the total concentration is. So we do have a calculator for that. So, okay, I guess I have that on the slide. Valproic acid displaces phenytoin from its plasma protein binding site. It also inhibits phenytoin metabolism. So we have so we have this corrected free phenytoin level equation with valproic acid. And again, we have a ClinCalc calculator that we can go to. So let's do that. I'm gonna click on my ClinCalc and switch my screen here. So now we're on our phenytoin correction for concurrent valproic acid on ClinCalc. So our phenytoin level was 15 and our valproic acid was 80. And we can click calculate. And our corrected free phenytoin level, remember, it's phenytoin is 10% free and the total therapeutic range is 10 to 20. So the free therapeutic range is 1 to 2. And so when we calculate this corrected free phenytoin level, it's somewhere between 20 and 26 for total, or 2 and 2.6 for free. So in any case, it's either the very upper range of normal or above, way above normal. So in either case, we're probably going to want to decrease our phenytoin dosing regimen, our dose rate, because our corrected level is on the high side or on the toxic side. So pretty terrific. All right. So there's a workshop for you to work through, acquainting yourself with ClinCalc and global RPH. So I hope you have fun kind of examining these cases together and finding out all the tools you have available to you. All right, thanks. Have fun.